am going to go over chronic illnesses in rehab nursing. So patients with chronic illnesses are cared for in a lot of places and sometimes even at home. So long-term care facilities, which you went to a long-term care facility in fundamentals for clinical, rehab agencies or institutions, outpatient clinics and providers' offices. Um, the nursing, the nurses that work at skilled care facilities have to be good at promoting resilience. So that means resilience means the ability to bounce back, like the ability to cope with an event that happened in your life. Okay. The goal is always in rehab and all nursing really is to foster independence. We want our patients to be independent or be able to function to their highest ability. Now, the role of the LPN in long-term facilities, you're going to be a charge nurse. You're going to have to give medications. You're going to have to do wound care and delegate assignments to CNAs and registered medication aides. I just went to a board of nursing meeting last week, and the regulations are going to change for registered medication aides so that they can now be giving medications in long-term care facilities, not just assisted living. All right. And you know how to delegate, right? You give specific instruction. You have to instruct how the task is to be done, list the information that needs to be reported, and you are still responsible for the outcome. So you have to supervise and circle back and make sure it's done. How does chronic illness impact people? It changes your family dynamics. It's a full-time job when somebody has a chronic illness in the family. So everything focuses on the person with the chronic illness. And then for the person who has the chronic illness, even their family too, there's a grieving process over what was lost. People with type A personality are especially prone to a feeling of loss of powerlessness. I mean, it can change your whole life. My stepmother just broke her hip recently. This was her fourth fall in a year. She lives at home with my father. And my father was really upset because she was in the hospital for a couple weeks and then she went to a rehab. And, you know, she did all the cooking and everything. And he's 88 and he had to fend for himself. He was kind of grieving about that. And he was worried about what was going to happen to her when she was in the rehab facility in the hospital. So, you know, it's a lot for them older adults to take that kind of information in. The chief goal of a long-term care facility is to promote independence, okay? We may not be able to restore somebody to their functionability that they had before the illness or before the accident, but we try to get them to the highest level possible. The nursing intervention, okay, so people who are like have hemiplegia or hemiparesis, they are going to be prone to contractures. So range of motion is something we should be doing for our patients, active range of motion or passive range of motion if they can't do it themselves, because that prevents contractures from happening. It does prevent joint immobility as well. So that's the purpose of range of motion exercises, is to prevent contractures. Usually you would do it 3 times a day to 4 times a day. And it doesn't increase muscle strength. It's simply to keep them supple, to prevent the contractures from happening. What type of activity prevents osteoporosis? It's weight-bearing activity. Swimming is a great exercise. I used to swim a lot, but swimming is not a weight-bearing exercise, so it wouldn't protect me against osteoporosis. But running is a weight-bearing exercise, so that protects me from osteoporosis. Now, people that are immobile are going to be prone to a lot of conditions that can happen to somebody that's immobile, like a DVT, because they're going to have increased venous stasis, which means the venous blood pools. It doesn't move as much as it does when you're mobile. In the nursing implications to prevent DVT, the ROM exercises SCDs, TEDHOs, and anticoagulants for prophylaxis. So I'm always asking, even when somebody's in the hospital, I want to know what kind of DVT prophylaxis they're on. And then, should you massage the legs of an immobile patient? No, you know you shouldn't do that, right? It could cause embolism if there's a DVT there. The GI hazard of immobility is constipation. So we want to make sure patients that are immobile, that we're increasing their fiber and their fluid. We always do those type of interventions first before we resort to stool softeners. So we're going to increase their activity and avoid constipating food like milk, cheese, and dairy, red meat, fast food, all the delicious stuff. Foods high in fiber include like prunes, fruit, and vegetables. Those are high in fiber. A neurological hazard of immobility is disorientation. People can become disoriented if they're in a facility for a long time. Now, when I worked in the ICU when I first started, this is like in the late 1980s, we had one row of rooms that had windows. We had another row of rooms that did not have windows. So for the people that we thought were going to stay for a long time, as soon as a room opened up with a window, we put them in there because they were less likely to suffer from disorientation because they could see night and day, right? They knew when the sun was out, they knew when the sun went down. And that's a big deal to prevent disorientation. Okay. You reorient frequently for people that are disoriented, but if they have dementia, it's probably not a good idea. You don't want to get them anxious. Okay. So the nursing interventions to prevent respiratory complications, turn, cough, deep, breathe, incentive spirometer, frequent repositioning, even in the wheelchair. Okay, they need to anyways to save their skin. So they need to shift their butt at least every hour, and every 15 minutes is even better. All right, so patients that are under chronic care or in a long-term care facility may develop pneumonia if they're immobile. So look for low-grade temps, tachycardia, because tachycardia is a sign the body needs more oxygen, crackles, and a cough. They'll have an increased respiratory rate, and listen to lung sounds so you can hear the crackles, and they'll have a positive sputum culture. The interventions for skin breakdown, turn Q2, Q1 if they already have the breakdown. If there is red skin that does not blanch, put a transparent dressing on it, and make sure your patients, orthopedic patients in long-term rehab, have a trapeze bar so that they can move themselves up in the bed, etc. That's great to foster independence. With the greatest concerns in long-term care, you want to prevent falls, and I know we talk about this frequently. You want to keep confused residents within the boundaries of the facility. You don't want them to go AWOL. Safety devices, when can we use those? Restraints can be used only if you have exhausted all other measures. Okay? Physical and chemical restraints are restricted by law and only used when a resident is a threat to themselves or others. You have to document all your failed efforts, and it may be justified if the family is unable to stay with the resident because they can keep the resident occupied and watch the resident. You're going to have to document, if you do apply a restraint, the time it was restrained, the condition of the patient, like the assessments. Make sure that you can slip 2 fingers under the assessment, restraint, sorry. So there needs to be 2 fingers between the skin and the restraint. Time the restraint is removed, and the condition of the patient when the restraint is removed. So again, implications for restraints. You're going to use the least restrictive device first. It needs to be ordered by a provider. You must obtain an order within 24 to 48 hours if it's an emergency. You are going to check on residents every 30 minutes to ensure the body is in good alignment and there's no problems. You do the skin checks and repositioning every 2 hours, and reassess the need for the security device every 4 to 8 hours. So you're constantly reassessing. When can a nurse apply one? If the family's unable to sit with them, and if all other methods have failed. So you have to document that, okay? And you don't do it because you're short staffed, okay? Don't ever use that as a reason to put a restraint on somebody. To help with confusion and disorientation, okay? Avoid placing the resident in unfamiliar situations. They like it to be like Groundhog Day. They do the same things every day, okay? So there's consistency with the schedule. Limit the number of choices they need to make, and avoid more than two visitors at a time, because it can be overwhelming to somebody who's confused and disoriented. And respond with honest and real information. And then if somebody is not confused and becomes confused, okay, assess for a physical cause. Like the most common one is a UTI in older adults, a urinary tract infection, but it could also mean constipation. Constipation could also occur in older adults once if they become dehydrated, and it may be the only reason you know that they have fluid volume deficit. Dehydration is another one, and if they're in pain. So if you're not medicating them properly if they need it. To keep the client safe while they're confused, use a nightlight, calm and reassure. Move them closer to the nurse's station. That is a great intervention for somebody that's confused and disoriented. Let me tell you, students often get confused. So somebody's confused and disoriented, moving them closer to the nurse's station is great. If they are trying to pull out IVs, NG tubes, other tubes, moving to the nursing station is not going to help. You're probably going to have to restrain those patients, okay? Because you want to keep the tubes in, especially if they have an endotracheal tube, all right? You're going to keep them active during the day to promote sleep, and use a bed alarm. And always, always, always make sure your alarms are on, okay? And active listening to determine what the cause of unrest is. All right, so some things you can do to promote independence, okay? Refrain from doing tasks the residents can do themselves. Give them a step-by-step instruction, for example, how to tie their shoe or how to, put on their pants, okay? Encourage the use of adaptive devices, and encourage them to pursue a hobby. Sometimes retired people are the busiest people I know because they have so many hobbies, which is great. It keeps them occupied during the day, and it keeps them busy. Okay, so to maintain cognitive function, if somebody is living in a long-term care facility, you can encourage them to watch TV shows like travel shows or scientific shows or public television specials, okay? Those are all good TV shows that can help maintain cognitive function. Crossword puzzles, math problems, card games. If they have poor vision, you can do a group puzzle. And bingo is good for that as well. All right, rehabilitation. This is where a disabled person is helped to achieve their optimal function, and it starts upon admission. So we want to minimize the deficit and maximize the abilities that are intact. So in other words, we want them to achieve the highest possible level of well-being that is possible for them. Okay, so older adults, are they receptive to rehabilitation efforts if they suffered a major loss of body function? No, they are not. So I told you earlier about my stepmother. Well, she wasn't very happy she was going to rehab. She didn't mind being in the hospital so much, but it was when she got out of the hospital, she had physical therapy coming to her house. I think it was like 3 times a week, but she was just over the whole thing. She just wanted to be like she was before she fell and broke her hip, so they're not that receptive to rehabilitation efforts, okay? So courage independence, let the patient do what they can do, give step-by-step directions, and encourage adaptive devices. Patients are going to feel better if they can do things themselves. And then a good nursing intervention for older adults that have lost a major body function, introduce them to another patient or a peer their own age as a support person, okay, that has the same issues. That may be a source of inspiration for them, okay? All right, that does it for rehab and long term care.